Next talk is by Dr. Lakshmi, laser cataract surgery. Where are we now? Welcome, Dr. Lakshmi.
Good morning, everybody. Thank you, Dr. Maliga, for giving this opportunity. It's nice to be in Kozhikode. So, laser cataract surgery or flax, where are we now? This will be my topic. Few words about the femtosecond laser technology. Already it has been discussed by Dr. Sija. It is a neodymium glass, 1053 nanometers near infrared wavelength laser, which is very accurate, ultra fast, and it is very focused up to 3 micrometers spot size. And what happens is there is laser induced optical breakdown or photo disruption. What is photo disruption? What happens is there is multi-photon ionization and small microplasma bubbles are created, and the gas inside the bubble expands and larger cavitation bubbles forms which coalesce, implode, and then there occurs the photo disruption of the tissue, and there is release of water and carbon dioxide. The laser is said that it is always from the posterior to the anterior plane. Posterior microcavitation bubbles scatter the laser beam, so it doesn't affect the retina at all. And the focus of the laser beam is maintained, and this avoids scatter before it reaches the target tissue. So it is a very focused laser beam that happens. There are mainly 4 femtosecond laser technology platforms. One is the Catalyst, LensX, LensAR, and the Victus. So we usually use the lenses, Alcon LensX platform. The procedure is pre-op. We have a Varion image guiding system. So we actually plan the cataract surgery before at the pre-op itself. So that was a Varion machine, and this is the planning of the cataract surgery at the Varion. So we can actually place the incision, know where the incision we want. We can plan the secondary incisions, the arcuate incisions, the capsulotomy, and everything can be planned prior to the surgery at the pre-op itself. So this is how a Varion image looks like the printout comes in like this. So in this, we have already planned the surgery, and we are going to do the surgery in a planned manner. So we can plan the arcuates. The arcuate, actually we can do 1 or 2 arcuate incision. All those, even the IOL power can also be calculated within the Varion itself. So coming to the machine proper, LensX machine, it has a laser console and a patient interface, basically. This is the laser console, which has a monitor, a display panel, and the machine as such. The laser delivery is done from the area. And there is a patient interface area where the patient will be lying down like this. The patient interface will be going into the patient's eye, and the docking is done from the patient side, and the patient is lying down like that. And this is the patient interface or the PI. The patient interface has an RFID. This is an RFID device. So it has a RFID monitor where it can be used for a single patient. And the blue thing, that is the patient interface, which goes into the patient's eye, which is docked into the patient eye, and the other one is the contact lens, which is used for different kinds of K values. So if the patient is having a steep K, the orange PI has to be done. That is, if the patient average K is more than 46 diopters, orange PI contact lenses should be used. For normal, that is from 46 to 41, the normal PI, and there is a blue PI which is used for the flat case, that is less than 41 diopters. So the primary procedure is the docking, where the PI, that is the blue thing, it goes into and sucks into the cornea, and it remains there. Docking is the primary part of the femto procedure. So what all can be done in an Alcon LensX? That is, we can do mainly 5 incisions, that is capsulotomy, lens fragmentation, the primary and the secondary incision, and the arcuate. Capsulotomy, it is significantly very precise. Capsulotomy size can be adjusted. Usually we do a 4.9 capsulotomy. We can do from 4 to 6 mm size. It is reproducible. It is very, the IOL will be very stable. IOL tilt post surgery will be very less. Lens fragmentation is the next step. That is, we can either do a cylinder or a chop, or combination of a cylinder plus chop, or a fragmentation into many small pies. This causes less effective phacoemulsification time, and it translates into less endothelial cell loss. So we can do a cylinder, we can do a chop, we can do a combination of cylinder and chop, and then we can do a frag. Arcuate incision is the next incision. We can either do a single arcuate or the double arcuate. Arcuate incision corrects the astigmatism for up to about 1.2. Primary incision, either you can do a uniplanar, biplanar, or a triplanar. We usually do the triplanar incision. It doesn't breach the AC, it just cuts and into the AC. The opening is done at the theatre. It is very regular and smooth and reproducible with minimum collateral damage, and there is great architectural stability for the wound. So primary incision also we can plan where we have to have, whether it is at the 180 degree, whether it is at the 20 degree, we can plan, and accordingly the arcuate incision size also varies. That is done prior to the surgery at the varion. Secondary incision, you can do either 1 or 2. So this is the pre-op data. What comes in the LensX console, that is the display. So at the LensX also, that is at the LensX theater also, what we can do is we can make small adjustments. We can adjust our incision if we feel that the patient is having a very sunken eye, we have to change the incision a bit, then we can do that. We can adjust the arcuate. If you want your primary to be a bit on the other side, if you want a bigger capsulotomy, we can all adjust there also. This is a small video which shows primarily how it is done. So this is the opening of the procedure. We are just owning our machine. Okay, we upload the patient details, and we have a warm-up time of about 10 minutes. There is a varion attachment to the LensX. The varion is uploaded into the LensX, and then we again upload the patient details, because the varion should be attached to the LensX and uploaded, so we can reciprocate it into the theater. This is the loading of the contact lens. You see the PI there. Okay. You are inserting the contact lens into the PI, and it is kept there. Now we do a pre-doc registration, that is comparing our patient's eye with the varion image, and the pre-doc registration is done. This is the varion that is attached to our panel. So PI is attached to the LensX machine. Red indicates that it is ready to be done, and we attach the PI into the patient's eye. So we are doing the docking now. The machine goes down. The cursor shows that it is moving down, and then it apposes into the cornea, applanates. The air bubble is just crossing it, and it is applanated. Now the PI is attached to the applanated into the cornea. So these are our incision, primary incision. Then the secondary incisions we have already marked, and then your capsulorhexis, which is 4.9, is done. Then the lens cut, we can see the chops there. We have we'll have 6 pies there post surgery. So what will happen is, now we'll reciprocate this into the OCT. I am adjusting it a bit now, because I wanted the image to be a bit in, the incision to be a bit in. So after doing this, what we'll do is we'll compare this with the OCT image. All fine minor adjustments can be done at the LensX itself. So next what we'll do is, we'll go into, now that we have planned the surgery, we'll compare it with the OCT. So this is the anterior segment OCT that is attached to the lens 6 machine. This is the anterior capsule. The anterior part is opposed now. The posterior part also is opposed. And we give a delta of 300 micrometers up and down. This is the capsulotomy that we are planning. This is the lens cut. Okay, lens cut. Actually, the lens, we are planning, that yellow portion shows that much area of the lens will be cut from there, from the lens 6. So we have we are proceeding with the surgery. Now this is the incision, primary incision. The effective tunnel length is usually from 1750 to 1850. This is a triplanar incision. I feel that this was a bit on the corneal side. So you can again go back, you can adjust it there, and then you can come back and do that final adjustment. The fine adjustments can be done on the table itself. So this is the primary incision being recorded. Now we'll go into the arcuate incision. So this is the OCT of the cornea. 80% of the cornea of the arcuate that we have chosen will be cut. So 80% depth of the cornea will be cut there. Okay. Now we are going to start the laser. So the capsulotomy is being done now. We can see the air bubbles coming up. So depending on whether the air bubble is coming totally up, we can know whether the rexus is complete or not. This is the lens cut being done. Okay. Now it comes from the posterior to the anterior. So the air bubble comes in last into the AC. Now this is the arcuate incision. This is the primary incision, and after that we'll do the secondary incision. So this was the primary incision being done. This is the secondaries. And we can also choose whether we want to do a primary or secondary. Any two cuts can be taken at the same time. So this was the main process of doing the lens 6. What are the contraindications? If there is corneal opacities or disease, previous corneal incisions, hypertony, blood in AC, poorly dilating pupil, obviously we can't do a lens 6. Severe neck and back problems where the patients can't lie down for long, kyphosis, nystagmus, gross nystagmus, we can't do. Sunken eye, small palpebral fissure where the PI can't go in, we can't do a laser surgery. The advantages is perfect capsulotomy. It reduces the phaco time and energy, regular incision, and it corrects cylinders to about 1.2 diopters. Thank you so much.
Thank you, Dr. Lakshmi, for that fantastic video presentation.